We'll discuss whatever we left from the previous first part of pre-implantation genetic testing and prenatal diagnostic genetic testing. So first is these are the soft marker, the doctor's venuses Dopplers. What is this? Increased impedance to flow associated with aneuploidies. Usually the aneuploidy associated with there will be increase in the impedance to flow, like the resistance will be increased doctor's venuses in aneuploidy, the cardiac anomalies, and adverse outcome. Inclusion in combined screening. If you increase this doctor's venous Doppler including to the combined screening test, the detection rate also increased 90 to 95%, and there will be 3% false positive reductors. Reserved for intermediate risk populations, monosomy X has the highest prevalence of absent doctor's venous Doppler flow because the impedance will increase. There will be an absent flow. Okay, you can see there will be a this is the reversals. There will be absence flow in trisomy 18. Very important. They can ask the MCQ question in the monosomy X. Remember, in the monosomy X, I'll writing here in the monosomy X, there will be a absent flow. Monosomy means there will be no. Mono means almost you can see this word is there. That is no word is there. Okay, no is there. So there will be no flow at all. Very easy to remember. If there is no monosomy mean no flow, that is absent flow doctor's venuses. Then trisomy 18 has high prevalence of reversal. You can see in the this is the reversal, this is the reversals, this is reversal, that is trisomy 18. Trisomy 18 is reversals. Okay, so if you see doctor's venuses flow has been reversals in, then you can suspect trisomy 18. DV flow reversal with other markers strongly, this will strongly indicate aneuploidy, whereas alone is poor screening tool. So remember, if along with other marker, then it will be strongly correlated with the aneuploidy, whereas alone is poor screening. If it is alone, there will be poor screening tools. Okay, then try the second soft markers. First soft marker I told, that is doctor's venous Doppler. The second soft marker is tricuspid valve Dopplers. The prevalence of tricuspid regurgitations varies with your gestational age. There will be some regurgitations, so it will vary with the gestational age and also increase as the NT measurement increase. So you can see the trisomy 21, the prevalence is 56%, 18 is 33, 13 is 30%, monosomy X is 38%, euclid is 1%. This is the tricuspid valve. You can see this is the tricuspid valve. So third, your additional soft markers. First is your doctor's venous Doppler. Second is your tricuspid regurgitation. Second is your, third is your frontomaxillary angle. You can see this is the frontal bone. You can see this is your frontal bone, and this is your maxilla. This is your maxilla. In between there will be angle. That is the frontomaxillary angles. This angle between the upper surface of the maxilla. You can see this is the upper surface. This is the upper surface of maxilla, and this is your frontal bone. This is your frontal bone is going. This is your frontal bones. In the mid sagittal view of fetal surface, you make this angle has to be measured. This is the angles has to be measured. So basically the frontomaxillary angle. This is substantial increase in your trisomy 21. In the Down syndrome, this substantial increase. Okay. The comparison of various first trimester methods. I told you various first trimester methods. What are the various first trimester methods? First is your maternal age. The detection rate is 30%, false positive is 5%. If you only take in the age, then it is 30% chances. Maternal age plus NT if you take, then it is 75 to 80%. The false positive is 5%. If you take maternal age plus beta SCG plus PAP-A, that is 60 to 70% chances of detection rates. This is as for the Prenatal Diagnostics 2011. Maternal age plus NT plus beta SCG plus PAP-A, that is 85 to 95% detection rates, plus combined test, that is NT plus age, combined test plus nasal bone, tricuspid. If you take this additional markers, tricuspid regurgitation, doctor's venous Doppler, then 93 to 96% detection rate will be found. So combined screening, that is NT plus double markers, if you take, is considered as the best first trimester screening methods. So basically you have a various methods. So if you take one method, that is combined screening, NT plus double marker has to be done. Any pregnancy you have to do in the first trimester to detect the screening. Very important. Now the inverted pyramid is going on, so you have to more be vigilant in the first 3 months. First 3 to 6 months, not in the later trimester, because if you detect in the first 20 weeks, you can terminate the pregnancy. You can decide whether she need genetic counseling, whether she need amniocentesis, chorionic venous sampling to diagnose the any abnormality, so that you can plan continue the pregnancy or not continue. You can based on that. Okay. So this is a case name of the patient, something is there. So you can see the fetus in this is the reports of a dual markers. Okay, combined trisomy 21 screening. You can see this is a papa and beta-cis level. Always in the refer you have to see the mom value. Okay, in the mom value you can see here the 1.23 is mom. Here the beta-cis mom is 1.00. Okay. So what are the things they have mentioned? Name, birthday, age of the sample date, fetus, weight, smokers, IBF, diabetes. These are risk factors they were added previous trisomy unknown pregnancy. Then the parameter, biochemical parameter, then ultrasound data, gestational age, CRL they have mentioned, knuckle translucency mom has been mentioned, nasal bone, sonographer. Okay. Then age risk they have calculated 1:7,730 only. If you take a biochemical 21 risk 1:7,463. Then combined trisomy 1 is less than. So this is the trisomy 13 plus NT. The calculated risk for trisomy 13 is less than 1 in 1000, which represents low risk. Okay, this is a normal case. So expressing the results, screening negative results significantly reduce the risk but does not guarantee unaffected fetus. If negative, that doesn't mean that is unaffected. So there will be a chance there will be a false positive rate, false negative rate. Some genetic disorder may not be covered by the test. Further testing not recommended. Later diagnostic testing still an options. If new finding ultrasound anomalies arise, if you get any anomaly in the future ultrasound report, then you can go for a diagnostic testing. False negative rate is low, but possibly due to sample error, low fetal fractions, mosaicism. Residual risk, even with the normal results, small chance of abnormality is there, 2%. Screen positive patients should be informed about revised risk of condition details and testing options. Screening improved detections, but is not a diagnostic. Genetic counseling should be done. Ultrasound diagnostic tests like CBS amniocentesis can be recommended for a if you screen get positive, what will do? Screen get negative, what will do? Okay. So about counseling is very important. All these tests. So prenatal diagnostic test, the counseling part. So in this positive result, you go for amniocentesis CVS. If diagnostic testing is declined, decision should be based on the ultrasound finding. If they are not willing, patient doesn't willing to do a diagnostic test, they should go for a targeted fetal animal score. Pills positive can occur due to biological lab factors, mosaicism, vanishing twin maternal conditions. Positive predictive vary by maternal age, disorder prevalence, lower prevalence, increase false positive rate. This is all over the first trimester screening. Basically, the first trimester screening you have to do maternal age, NT scan plus your dual marker screen. That is a combined test. That's a very good detection rate. If you go addition of these things like additional soft markers, NT plus dual markers plus soft markers, then that will be the increase in the detection rate. Okay. So now basically the second trimester screening, what are the options we'll see. The second trimester screening you carry out between 15 to 20. When you will do 15 to 21 weeks of gestational age, using what are the methods you have? You have options of ultrasound scan, maternal beta-cis level, alpha protein level, and unconjugated estradiol, plus you add inhibin A levels. So this is all three is triple marker. Then if you add inhibin A, is quadruple markers. Okay. So here remember, PAP A is not in the very important questions they can ask in the second trimester screening. Which biochemical marker has not been used? Remember, beta-SCG PAP A is the first trimester screening. Then after that PAP A has been excluded. Then you added these things. Beta, if you it is a triple marker, beta-SCG alpha protein unconjugated. These three in the triple marker. If you add inhibin A to that, that is a quadruple markers as per the recent guidelines. So second trimester you have a ultrasound, because this is the targeted fetal anomaly scan. You can go for these scans, very important. Then serum marker, if you go by triple markers, is alpha fetoprotein, beta ECC, unconjugated estradiol type 3. Then quadruple markers, alpha fetoprotein, beta ECC, unconjugated estradiol, inhibin A plus pentascreen. If you add HSCG and inhibin A, unconjugated HCG, estradiol. So basically biomarker and the source and normal pregnancy trends, trisomy 21, other relevant conditions. We'll see what are the beta-SCG value products. Usually the production source is beta-SCG, I told, produced by the placenta. It will support corpus luteum functions. Normal pregnancy trend, what will happen to beta-SCG trend in the pregnancy? It will peak at 15 weeks, then decline rapidly until 17 weeks, followed by a gradual fall in 22 weeks. But in trisomy 21, what are the effect in the pregnancy? In trisomy 21 patient, increase both trimester. In the past also increase, in the second also increase. It did not decrease, because the normal phenomenon is decline rapidly until 17 weeks, then follow a gradual fall. So basically, if it is a trisomy 21, that beta-SCG level is increased. HCG is high, but H is high, but it is down. So other relevant condition, not a key marker of trisomy 18, very important. Alpha fetoprotein levels It will produce by the fetal liver, very very important, liver and GI tract. It will excreted in urine into amniotic fluid, normal level in on after pregnancy. So if it is affected, trisomy 21 reduced by 25% in trisomy. So beta SSG will increase, HCG will increase, but alpha fetoprotein level will be reduced by 25% in trisomy 21 pregnancies. Increase in open spina bifida cases. It is increase in open spina bifida in cases. So very very important. So if it is Down syndrome, HCG will increase, alpha fetoprotein will decrease. If it is a neural tube defects, open spina bifida cases, then alpha fetoprotein will increase. Then unconjugated estradiol or free estradiol derived from the fetals adrenal glands metabolize in the placenta, level increase gradually during the pregnancy. So it will gradually increase. So it will, but in case of trisomy 21, the unconjugated estradiol 25% cases reduced by 25%. The lower level indicate placental dysfunction. If it is low, then it is a placental dysfunction also. Inhibin A is produced by the placenta. Inhibin FSS release elevated, normally elevated in pregnancy compared to non-pregnant women. It increased 1.77 mom in trisomy 21 in the second trimester, not used in the trisomy 18 risk calculations. Okay. So next test, we have options for non-invasive prenatal diagnostic testing. Very very important. Repeatedly we are telling diagnostic. This is not a diagnostic test. It is also a very very wrong. This is a not a diagnostic test. It is a screening test. Okay. So non-invasive prenatal testing, cell-free DNA testing. It is highly advanced screening methods used to detect chromosomal abnormality in the fetus by analyzing cell-free DNA in the maternal bloodstream. The test is particularly effective detecting trisomy 21, Down syndromes, trisomy 18, trisomy 13, though it is accuracy vary across different conditions. NIPT is performed using maternal blood sample. Typically, you have to take 10 weeks of gestation because fetal fractions has not been formed before 10 weeks, so you have to take after 10 weeks only. Provides a risk assessment rather than a definite diagnosis. Very very important statement. Risk assessment only, not a definite diagnosis by NIPT. So NIPT is the only by screening test. If a high risk result is detected, confirmatory diagnosis has to be done. Chronic milk sampling and is recommended. Okay. So basis, what is the basis of NIPT? If you go for base, what is the basis pathology? What is basis the things why you are doing this test? Because you know trophoblast cells release cell-free DNA, which makes up approximately 10% of the DNA of maternal blood. What will happen when the trophoblasts get degenerated or it will get apoptosis happen in the trophoblast cells? It will release the cell-free DNA. That cell-free DNA is transmitted to the maternal circulation through the fetal circulation into the maternal blood. Approximately, it will continue only 10% of the DNA of the maternal blood. So if the fetal DNA clears from the maternal bloodstream soon after delivery. So very very important, but DNA will be remain is there in the maternal blood. It will clear only after the delivery, making each pregnancy specific. So testing measure DNA volume from specific chromosomes. Trisomy is detected if there is an excess DNA from a particular chromosome, extra chromosome, trisomy 21. So basis is trophoblast cell release cell-free DNA that will circulate to the maternal blood. You have to detect in that. So test, if you detect the test accuracy, that NIPT has a detection rate nearly 100%. Very very important, nearly 100%. If you done this test, your trisomy 21 is very very easily detected. So remember this statement, 100% detection rate for trisomy 20. This can be MCQ in your exam. Trisomy 21 NIPT has 100% detection rate. Then trisomy 20, trisomy 18, it is 98%, 198. Oh, very fast for the value of 81%. However, sensitivity is lowered for trisomy 13. Very very important. So remember, 21 is 100%, 18 is 98%, but 13, if you take 13, trisomy 13, it is very low sensitivity because due to likely low guanine GC content in the chromosome 13, and it is very less reliable for detecting monosomy X chromosome, that is Turner syndrome के लिए. Thus NIPT is very low accuracy compared to other chromosomal abnormality. So very very important, NIPT has a good accuracy. If you compare with 21, 18, 13, 21 is 100%, 18 is 98%, for 13 it is only very low, and monosomy it can less reliable. Okay. So what are the benefits of NIPT? If you go by NIPT, it is a very very important. What are the statement benefits? It is a non-invasive testing. It require only maternal blood sample. Now, unlike invasive procedure like CVS and immunocentesis, so it is only required blood samples, not required any tissue from the fetus. Okay, so if you take a CBS amniocentesis, there is risk because there will be a chorionic village sampling. If you do chorionic village sampling, there is chance of placental hemorrhage. Amniocentesis, there is chances of injury to the fetus part, fetal amniotic fluid leakage, chorioamnionitis pictures will be there. So this is a non-invasive. This is the very basic things. So pregnancy specific cell, because it is cell-free DNA, because you know, if you detect cell-free DNA, if you do NIPT, then that cell-free DNA only for that pregnancy, not for the previous pregnancy, because if immediately after delivery, the previous pregnancy cell-free DNA in the maternal environment from the fetus has been already clear out. So it is very specific to the particular pregnancy after delivery. The results are not influenced by the previous pregnancy, and quick result, only 3 to 5 working days, 3 to 5 working day it will give. So if you can go for a early decision making, high sensitivity and specificity. Okay, very very important. What are the disadvantages or NIPT? The technical limitations. The technical limitations is 2 to 7% cases results inconclusive due to low fetal DNA fractions require retesting. 20% of inconclusive tests fail upon testing, retesting. 20% of inconclusive tests fail upon need a retesting. Because in 2 to 7% there will be inconclusive due to low, because the test disadvantage is there will be a low fetal fractions, very very important. The low fetal fraction is the only disadvantage in this case that will cause inconclusive results. So you need a repeat testing. Low fetal DNA fractions common in obese men. If you have obese women, the making the test is unreliable. Vanishing, if there will be a vanishing twin syndrome, the leftover DNA fragment may falsely suggest it is a trisomy in the surviving twins, because the vanishing twin already the damage, there will be trophoblast degenerating, apoptotic trophoblast is more in the vanishing twin that will circulate in the maternal fetal blood, so that will cause increase suggest trisomy in the surviving twin. Placental mosaicism, when the placenta carries a abnormal cells but the fetus does not have. If a placenta have mosaicism, suppose placenta has mosaicism, if you take trophoblastic tissue, cell-free DNA from the placental tissue, because it is from the trophoblast of the placental tissue, so it will carry abnormal cell, but the fetus does not have this, so it will wrongly inform that this have a chromosome, incorrectly inform that it is a chromosomal abnormality. So very very important. First thing, it is the technical limitations. 2 to 7% cases there will be inconclusive result due to low fetal DNA fraction. 20% of inconclusive tests to follow from trace testing. There will be low fetal DNA fractions in obese women. Then vanishing twin syndrome. There will be, because there will be a leftover more DNA fragments in the dead baby, that will cause a wrongly high chances of falsely trisomy 21 in the cervical twin. Placental mosaicism, but placenta has defect. Placentas carry abnormal cell, but the fetus doesn't have, so it will incorrectly replace chromosomal abnormality. Unexpected maternal findings. Sometimes what will detect maternal genetic conditions, or even mother have pregnant, even cancers, ethical psychological challenges will be there. High, because this test is high cost, making accessibility an issue. It is not recommended in microdeletion testing. Microdeletion is not detect. Very low positive predictability in low risk populations. If it is low risk, there will be very low positive predictability. The futures, what are the futures of NIPT? The expected to become the primary screening methods for chromosomal abnormality. Expected it can be a primary screening method for chromosomal abnormality. You can the RCOG advise the all obstetrician to be trained counseling the patient about NIPT. The UK national guideline currently recommended NIPT is a contingent screening testing offered to women whose first time screening indicate a high risk of 1:150. If it is high risk, then you go on NIPT. The ACOG traditional screening as a first line test. Recommend that high risk NIPT result confirm with invasive diagnostic testing. If NIPT result inconclusive or failed, SUG recommend fetal ultrasound or invasive diagnostic test like CBS amniocentesis should be done. So positions, what are the current position of the NIPT in the screening algorithm? As a secondary screening methods, NIPT for women at high risk for NIPT, if it is age at delivery is more than 35, ultrasound has a finding increased risk. There will be a personal or family history of prior pregnancy with a trisomy, or past a second trimester screening test is suggestive positive. Parental balance translocations, Robertson translocations with increased risk of 21/13, then you go for a NIPT as a secondary screening method. As a contingent screening, population screening, conventional method, biochemical and ultrasound. If it is high risk, invasive testing. Intermediate risk, NIPT. Low risk is routine follow-up labs to be done. If a primary screening taking, primary population screening test, the risk more than 1 in 1000 generally category is low risk. Risk more than 1:250 is high risk. Indication for invasive testing, some center cutoff is 1:50, 1:150. So if it is 1:250, then you go for a direct invasive testing. Risk then 1:250, then you go for 1:1000 low risk. Okay. So this is the report of 38 years. So one is risk triple, you have done a triple screening. So indication, clinical indication, what is the clinical indication in this example? You can see In this example, you can see clinical indication for NIPT 1:128 degrees, that is 1 is less than 1:150. So you can go for NIPT testing. There will be a low risk after all trisomy 18, 20, 30 monosomy low risk. Okay. Test integrated across the first and second full integrated NT scan, PAPA, quad 15 to 18 weeks, result after quad. Serum integrated, if you do serum integrated, PAPA done, quad is 15 to 18, result after quad. Stepwise sequential combined test. Full integrated is NT you have to done, PAPA has to done, quad has to result after quad. Serum integrated, PAPA, quadruple. Stepwise sequential, you have to do a combined screening test, that the NT plus this NT plus your biochemical. That is HCG beta dual marker, high risk, CBS go. If it is low risk, quadruple. Stepwise sequential. This is stepwise. And contingent means high risk or intermediate risk, low risk. If it is based on the intermediate, second trimester screening has to be done. So optimal first trimester screening, low risk, additional little impedance, intermediate risk, no marker, reduce risk substance, high risk, further increase the risk, help decision invasive testing. So we'll talk about the rest part in the next sessions. Please cope with me. If you like this sessions, please subscribe this channel. Thank you.